Good morning, everyone.
Morning, Professor.
Okay, guys, so we're just going to spend time this morning in class just going over stuff that you would have to know for test 2, just to make sure it's fresh in your mind and you feel better about it. So with test 2, there is, like, the first half of the test is going to be about chapter 13, which will have all of the IV stuff and your fluid and electrolytes, and I don't know, there's a ton of stuff like that in there. And then the second half is all GI everything. So I'm going to start with the second half first. Let's just go over some of this GI stuff, and then we'll go over the harder stuff last. All right, so the chapters that you're going to have to remember for this. Here, let me flip to a different page for a second. So for the GI chapters, it's going to be Chapter 43, Chapter 44, Chapter 45, and Chapter 46. So if you guys remember back to when we started talking about this a little bit, that first chapter was just, GI assessment type stuff. So out of that, things that I would pay more attention to. So in the beginning of that PowerPoint, I talked about like the different processes that happen throughout digestion. You need to be familiar with what happens where. So what happens in the stomach? What happens in the small intestine? What happens in the large intestine? There's a specific question that you're going to have about that. So you need to be able to tell what happens where. Let's see. Other stuff that we talked about in here, we briefly mentioned a lot of different assessment stuff having to do with GI. So like if you had someone that you were assessing and you were worried that they had a bloody stool or something, what the different types of bloody stools meant. So remember we said if you had bright red blood, where would that be at? Upper or lower GI?
Bright red is upper. No, I'm sorry, lower, because it'd get darker if it was upper.
Correct. And then
Tari would be upper, right?
yes, you're correct. So know that kind of stuff. And I know we talked about like if someone had like rectal or anal bleeding and what that would look like, so know those types of things. And then also in that chapter, we talked about a bunch of different testing. So we talked about like upper GI tests. We talked about barium enemas, EGDs, colonoscopies, all those types of things. So I definitely would take a look at those. I don't ask you about everything, but make sure you look through those. You do have at least one of those tests on here. So that's that chapter. It's not really a ton of things out of there that you're going to have to really know well. Then the next chapter would have been the one about GI treatment modalities. And this talked about all of the different types of tubes. We talked about the NG tube and, reason why you would get intubated with that. Do you guys remember some of the reasons why you would have to have an NG tube?
To decompress or lavage the stomach.
Okay. What else?
You need like a high caloric diet for some reason.
Okay.
That's not specifically NG2, but yeah.
Okay, that's all right. What else?
Facial injuries.
Okay. What do we see NG tubes most likely put in for most of the time?
Maybe when someone's NPL or if they need nutrients, because you can feed someone through an NG tube.
You can. That's another reason why you would get it. But the thing that we most often see them put in for is when someone has a post-op ileus. And so we have to put it in for decompression of the stomach. So, you know, we remove all of that extra gas and fluid from the stomach so they're not vomiting all the time. That's the most common reason why you see it someone have that in. Do you guys also remember we talked about if someone had esophageal varices, there is a type of tube that you could use for that? Do you remember what that's called? It's that Senstaken-Blakemore tube. So this is that tube that you can put in you can like blow it up in their esophagus, the lower esophagus. There's a balloon there, and it puts pressure on those esophageal varices to get them to quit bleeding. So that's another reason why you could have this. Other things that we talked about in here, we talked about the specific types of tubes. So the one that we all know most is that Salem sump tube, and that's the one you guys all had in your lab bag. So that's the one that has that blue port. What's the purpose of that blue port?
For venting,
Yeah, it vents.
prevent sectioning of the lining of the stomach.
Okay. And so is there a reason that we would have to like put air in there every so often?
It's to keep it from sticking, right?
Okay. So you guys know, you're familiar with what that blue part of the tube looks like, right? So when someone has that in, you don't want to have that laying like really low down. You want it kind of facing up and being like at the upper part of their body when they're in bed, so that it doesn't leak out. Like there's contents that can leak out. So as you're like sucking all of these contents out of their stomach, you know, that stuff could go down through there as well. So by putting air in there every so often, you kind of cause a barrier so that nothing comes out of that tube. Does that make sense? Yes, no?
Yes.
Okay. So definitely kind of be familiar with that tube in particular. I think that will be helpful for you. Let me see, what else? Is there anything specific about NG tubes that you think, you know, like taking care of them day to day, that you think you would need to know? Tell me some like principles for taking care of an NG tube.
You need to flush it regularly so it doesn't get clogged.
Okay. So what do you do for flushing it?
Warm water, right?
Okay.
Although
What
I've heard some old style nurses use like cola, but I know we can't do that.
Yeah, we're not supposed to do that. What do we put through it? Just warm water? And you said what type of syringe would you use?
I guess a larger one so there's less pressure.
Okay, so probably a 60 cc syringe, right?
Yeah.
All right, what else?
Flush it every time you use it, basically, like
Okay.
before and after admin,
Okay.
feeding.
Okay. What else do we have to do every time we use an NG tube?
Make sure it's in the right place.
Yes, and how do we do that?
Uh,
How do you check?
aspirate the contents.
Or by
What do we do with the aspirated contents?
Checking the pH.
Okay, the pH, that's a good one. What do we want the pH to look like?
Unsure.
We want the pH to be acidic, because if it's acidic, we know we're in the stomach. Okay, what were you saying, Sammy? Since we cut you off, I'm Apologize.
I said you could also get an x-ray.
Definitely. So when you first put it in, you always want to get an x-ray. That's like your best way of checking to see if you're in the right spot. However, every time you check, which we're supposed to check every time we use it, we don't want to get an x-ray every time because that would be ridiculous. So only when you first put it in would you get the x-ray. What else could you do to make sure that it's in the right spot?
You could check like the tube length that you marked off.
Definitely. And so you'll see when you start practicing, there's so many people who take shortcuts and don't do everything they're supposed to do. So even though that's a great way to check, you'll see hardly anyone does that, which they should. All right, so just remember, you always should be checking 2 ways to make sure that you're in the right spot. That's a huge deal there. All right, so we know we're checking for the right spot. We talked about flushing. What else would we have to know about just taking care of an NG tube day to day?
Maybe do patient care like skincare around their nose to
Okay.
make sure it doesn't dry out.
Okay. What else? Don't we have to check residual?
Yes.
This is only if they're getting tube feed. Why do we check residual?
To ensure that they're processing the feed.
What's the purpose of that?
You don't want to overfeed them.
Okay. So the biggest thing with residual is when the reason we're checking it is because we want to see that they're tolerating their tube feed okay and that they're not aspirating. How do you know when someone's aspirating?
They're
Um,
choking.
yeah, you would hear them choking or you would hear gurgling maybe.
Okay. So when you listen to their lungs, you could hear crackles. And sometimes you don't even need to listen to their lungs. You can hear them without even putting your stethoscope on them. What else?
Pulse ox might be lower because of
Okay.
yeah.
That's a good thought. So typically, when they're, people, so many people silently aspirate. So it's really difficult to see sometimes when someone actually does that. Now, again, those things that you guys said were great things to, pick out to see if someone has aspirated. But just know that sometimes, regardless if you're really good at your assessment or not, sometimes you won't pick it out and they'll still be aspirating. So just realize that. Now, if you're just feeding someone who doesn't have an NG tube and you're worried about them aspirating, that's a little bit different because they're going to cough while you're feeding them. Um, they might do some weird things like that, or maybe like pocket their food in their mouth or something. So just a teeny bit different with tube feed. Okay, is there anything else we should be looking at when we have someone that has tube feed going every day?
Is their
You,
weight?
go ahead, Joe.
Oh, I said their weight.
Okay,
And maybe their blood sugar.
maybe. What about like the characteristics of what's coming out? Right? So in your canister, you want to see that you have stuff coming out. So every time you go in the room, you should be looking at that. So if stuff isn't coming out, maybe you need to troubleshoot to figure out what's wrong. A lot of times there's like a filter that you have on your canister, and sometimes that filter is clogged and you need to change the filter to get it to suck better. Sometimes it's just the way, maybe your tubing is clogged, so maybe you just need to flush, like Brandon was saying. So you definitely always need to look at that canister to see that you have stuff in there. Check out the contents of it. What does it look like? How much is it? Those are important things you need to be looking at every day. Okay, other things that we talked about in this chapter. We talked about people who um, have to get different types of feedings. You know how, like we said, there is a continuous feeding, there is a bolus feeding, and then there's even like a cyclic feeding. What would be the purpose of a cyclic feeding?
Would that be to like wean them off the continuous, or get them to interact with other people?
Kind of. So if I have someone who seems to be improving and I think, okay, well, I'm going to put them on a diet now, typically they don't eat enough at first to be able to sustain themselves, nutritionally. So typically they're going to be on actual food and tube feed at the same time. So sometimes you'll see people just cycle their tube feed at night only. So they'll get tube feed on a pump overnight. And then in the morning when they get up, you take them off of that. And then they'll get a breakfast tray, a lunch tray, and a dinner tray so they can actually try and eat during the day. And then once their appetite picks up a little bit, then you would get rid of the tube feed altogether. So that's like a cyclic feed. So when we're initiating tube feeding, usually we're going to have an order from the physician that will tell us exactly what he wants us to do. So he may say, I'm trying to think of a name of a tube feed. Give, I don't know, give the tube feed 10 cc's an hour until you reach a goal rate of 40 cc's an hour. Hold if a residual is greater than 200. Like it would read something like that, So if this was the case, you would be putting this tube feed on a pump and you start it slow. Why do we want to start it slow?
So they can tolerate it better.
Yes, because remember when we talked about dumping syndrome and we said if you get things too quickly, if that movement of water that happens, from that goes into your small intestine, if it's too quick, that causes that dumping syndrome. So we definitely want to make sure we start it slow and then move our way up. So like if you were doing this, if you were a nurse, you would just start it, at that first rate that he said. And then after an hour, if you see things are going well, then you go ahead and move it up to 20. And then after an hour, if that goes well, then you move it up to 30 until you get up to your goal rate, and then you just leave it there. Does that make sense?
Yes.
Okay. All right, so let's see what else is in this chapter. All right, what are some common complications of enteral therapy? Enteral therapy meaning tube feeds.
Aspiration.
Aspiration. What else?
Dumping syndrome.
Dumping syndrome. What else?
Tube displacement.
Okay. Anything else? If someone isn't tolerating their tube feed, what are you going to see?
Nausea and vomiting.
Okay. Maybe even
Diarrhea.
diarrhea. Yeah, a lot of people will have that. So those would be complications. And then what's one that you guys are not remembering? Common one.
Unsure.
So it's your blood sugar. You can have hyperglycemia. So that's something that you definitely want to watch for. And then dehydration, you could have dehydration here. Constipation sometimes, just depending on, what type of tube feed you're getting. So just remember some of those complications as well. Okay. What I would do if I were you guys, just to remind yourselves of certain things about this stuff, you could go into your ATI, into your modules, the skills modules, and there's one specifically about NG tubes that has all of this stuff in there. So you could like re-look at that. Here, I'll show you what I'm talking about. If I have it up here, hold on. Okay, so inside the module, there is this thing called accepted practice. And I get that these modules are long and maybe you don't want to mess with them, but in accepted practice, all this is stuff to read, so you can go in here and look at specific things about NG tubes just to remind yourself of some of that. Like this has, hey, this is how you insert it. Here's some basics about it. Here's the different types of tubes. It talks about all of these things. There's a ton of stuff in here. So that would be really helpful, I think, if you have forgotten anything about that. So just an option if you wanted to do something like that to help as you're studying. Okay, so the next chapter we were in. This would have been oral and esophageal disorders. So we talked about a ton of stuff in this chapter. It was kind of a weird gamut of everything, but I only picked out certain things from this chapter to put on the test. So I'm going to kind of go over some of that. So when we talked about oral cancer, what do you guys remember about oral cancer?
You sometimes don't notice it right away.
Okay. What's it look like?
It usually starts as like a little red bump in the mouth.
Okay. What else? Does it hurt at first?
No.
No. And sometimes like maybe you're messing with your mouth some way, like maybe you're brushing your teeth or something and you irritate it a little bit from the toothbrush and it could start bleeding. So it could be something that's a sore in there that you don't really realize you have because it doesn't hurt, but then it could start bleeding and then that might be like your cue that you have something wrong. Now it's raised, right? Remember it's raised a little bit and it's like a hardened ulcer. So it's kind of not soft, it's hard. So when it starts to get worse, that's when you start feeling the pain. So when it gets bigger, you are going to start feeling that it hurts and you're going to start having difficulty chewing and swallowing because it's getting bigger. Do you guys remember what you can do to prevent oral cancer? Remember we had like 4 different risk factors that made us more at risk for this. So something you could do to prevent it.
Don't use tobacco products.
Okay, because smoking will be a risk factor here. What else?
Alcohol use is a risk factor.
Okay. And there's one thing in particular I'm trying to get you guys to remember. There's a vaccine. Remember the HPV vaccine? So if you had HPV, if you had an infection with that, that's going to, contribute to your risk of oral cancer. So if you wanted to prevent it, essentially getting that HPV vaccine would help you to prevent it. Okay. All right. So remember, as we were talking about oral cancer, we said, if you catch it quickly, you could probably get that area removed, no problem. But if it gets bigger, sometimes it will, go into your tongue and cause problems like with tongue cancer and stuff. So remember we started talking about what a hemiglossectomy was and a total glossectomy. What's a hemiglossectomy?
They remove half of the tongue,
Okay. And
and then a
so,
total obviously would be the whole tongue.
yes. So if we had to do that, what do you think this person would have trouble with after the surgery?
Talking, eating.
Yeah, so especially the total glossectomy. Can you imagine trying to eat if you didn't have a tongue? You wouldn't be able to protect your airway very well, right? So it's a huge deal. So definitely they're going to have difficulty communicating. So you definitely want to make sure that if this person is someone who has to get this done, that you talk about that before they get the surgery so that you can kind of come up with a way of communicating so they don't have any issues afterwards. Let's see what else. All right, we also talked about how this can be very painful. So when they get this surgery, um, we talked about some interventions that you could do. You know, we talked about mouth care and how you could come up with your own type of concoction that might help with some of their soreness in their mouth. Um, they do have viscous lidocaine, which could be used that would help, you know, with the pain. It kind of numbs your mouth. We talked about preventing infections, and this person is going to be really at risk for that after surgery. So we want people to, like, you know, we want to restrict visitors basically so this person doesn't get sick afterwards. Um, and then this is like a big deal with your self-confidence and everything. So even though this is inside your mouth, how would you feel if you didn't have part of your tongue or your whole tongue? You would feel weird, right? And so like talking to people and stuff, it would just be strange. So it's going to be kind of a hard thing to get used to. All right, so that was the oral cancer stuff. Then we get into neck dissection. So, you know, maybe your cancer started out as an oral cancer, but then it got bigger and it moved and it traveled. So if it's in your neck, typically this could have started out, you know, in your mouth, and then it just moved into your lymph nodes and traveled. So the neck dissection is a huge surgery where they actually have to make like a huge long incision here, and they will open up, like if you look at that picture in the book, they like open up the face almost. It's crazy how much they open you up. And they take a ton of stuff out during the neck dissection, right? So remember we said they take out that sternocleidoid mastoid muscle, the inner jugular vein, your spinal accessory muscles, all of this stuff, along with your lymph nodes. So you could easily, after the surgery, have like an indent right here. You know, after they close you all back up, it's going to look like you're missing a lot of stuff there. So you actually physically look different after the surgery. So they do have reconstructive things that they could do for that. But again, this is a huge deal to go through the surgery. So we said, remember we said you have this lung incision, you have a trach afterwards. You're also going to have a Jackson-Pratt drain coming out of here. So things that we would want to consider after this type of surgery, you know, obviously we're going to be watching that incision. We want to make sure that, you know, we're preventing infection. We're going to watch that drain to make sure that it's not putting out too much and that the color of the drainage looks okay. Because what color do we want to see?
I think like a purulent color.
We don't want to see purulent. We want to see a red color coming out, right?
Okay.
So we want to see that it looks like a bloody drainage, and then eventually it's going to look like a straw color. That's what we want to see. If we see anything other than that, that's a problem. So like if we see white drainage coming out of there or purulent drainage, like you were saying, that would be a problem. So you'd have to let the physician know. Okay, other stuff with the neck dissection. Do you remember in the book it talks about how you have to do those special exercises, like those shoulder exercises and stuff, because they take that muscle out of your neck and it would cause like shoulder drop and everything if you didn't do those. So that's something that's important. And then airway is going to be our biggest concern after the surgery, right? Because we're right there by the neck, by our airway. So huge concern that we want to make sure that they can maintain their airway. We talked about how, you're probably going to have to be doing suctioning and stuff like that afterwards because they're going to have lots of secretions. To listen for things like stridor and things like that, that would be a problem. You would want to watch for those types of things. Okay, so the other thing that we talked about was different kinds of things that go on with your esophagus. There's a bunch of different esophagus disorders. So one in particular that I want to talk about is Barrett's esophagus. What do you know about Barrett's esophagus?
Is it like a precancer?
It can be, yes. What causes it?
Is it genetics?
No, it's all about GERD. So this
Okay.
person has had GERD over a certain period of time that has not been taken care of. So they keep having this GERD and all of this stuff keeps coming up into their esophagus over and over again. And so that is causing changes in the lining of their esophagus. So it actually changes those cells. And so those cells become precancerous. And then over time, again, if you still don't do anything about that, that could turn into esophageal cancer. So it all has to do with GERD. So the big thing here then, we could prevent esophageal cancer by treating GERD, right? So that would be something. And then if we know someone has Barrett's esophagus, then what we would do for this is we would bring them back every so often to do upper GI tests, like an endoscopy type of a test. And that way our camera would go down and it would look at those cells to make sure that they aren't any different. So you just kind of monitor the changes every so often to see if they get any worse. Now, when they do get worse, then you would have to do something, right? So you would do probably an esophagectomy at that point if that was, if it came to that. So remember, an esophagectomy, they're taking out your esophagus and then reattaching everything, after that. Other things they could do an ablation, and we also mentioned some kind of other photodynamic therapy that they could do. But yeah, so just the main thing though, just about Barrett's esophagus, just remember it's all has to do with GERD and that you have to keep monitoring it like kind of frequently to make sure that that's not getting any worse. So couple other things that we talked about a little bit in here. We did talk about GERD and we talked about hiatal hernia. So I guess I would just kind of know a little bit about those. And then the last stuff would be that next chapter. So the next chapter was the gastric and duodenal ulcer chapter. So in here, the first thing we talked about was gastritis. So remember, gastritis is like kind of something that would happen before you would get to a peptic ulcer. So over time, you're going to have that lining of your stomach or your intestines kind of breaking down over time. And so if you just have gastritis, it just looks inflamed and reddened at the time. If you have it for long enough, you may start to see a little bit of erosion, but then as it gets worse, and it maybe if you don't treat it, then it could turn into a peptic ulcer. So the peptic ulcer, you're going to have those big erosions, and sometimes they'll actually go all the way through to where you would have a GI bleed from a peptic ulcer. So you definitely need to know about that. What are some things that can cause gastritis?
Foods, maybe smoking, drinking, things like that.
Okay. I kind of heard someone say something else. What was that?
H. pylori.
H. pylori. What else? What are some things that people take over the counter that could cause this?
Acetaminophen.
Yes. So things like aspirin or NSAIDs, people who take a lot of those over time, that can definitely cause this. So those would be big things to think about with gastritis. We also talked about peptic ulcers. So remember with peptic ulcers, the big cause for those would be that H. pylori. So it could cause both. It could cause gastritis, it could cause, peptic ulcers, but like 9 times out of 10, most of the time, the higher percentage of people who have peptic ulcers are going to have them caused by H. pylori. Now, to treat that, we have to treat it with antibiotics and either proton pump inhibitors or H2 receptor antagonists. So, antibiotics. You typically will have to take those for 10 to 14 days. So you would want to make sure that your patient understands that they have to take it for that amount of time. And then why would we have to take proton pump inhibitors or H2 receptor blockers along with the antibiotic to fix this?
To lessen the amount of acid.
Okay, what else?
To allow it to heal.
Yeah, it actually helps heal up the ulcer. So there's certain medications that you can take to help with your symptoms, but they don't fix the ulcer. But these two things actually do. So proton pump inhibitors and H2 receptor blockers, if you take those for a certain period of time, they will actually help heal up the ulcer itself. So our goal then for this, fixing this H. pylori infection would be to give them pain relief, to get rid of the infection altogether, to heal up the ulcer, and then prevent reoccurrence. And we prevent reoccurrence by getting them to take the medication for the amount of time that they're supposed to not stop it before, the physician tells them to. How do proton pump inhibitors work?
They reduce the gastric acid secretion.
Yes. So that's something that you need to know, you guys. You have to know about these particular drugs for this test. What do H2 receptor blockers do? How are they different from PPIs? All right from your PowerPoint here, you guys, it says these drugs work by blocking the action of H2 receptors of the parietal cells. So they inhibit gastric secretion, but their effects only last for 12 hours. So if you had to choose between a PPI and an H2 receptor blocker, the PPI is probably going to work a little bit better, but it doesn't mean that that's the only one you could use. You could still use H2 receptor blockers. They just would have to take them for a longer period of time. And, some people are allergic to certain things and can't take them. So, maybe you would have to go with one or the other because of that. Okay, other stuff. you know how we mentioned how when you have a peptic ulcer, sometimes you can have a GI bleed that goes along with that, right? So if you have someone who has a GI bleed, what do they look like? What kinds of signs and symptoms would you have?
I think the main thing is like the coffee ground emesis, which means they're basically vomiting up blood, right?
Okay, what else? Geez, none of you want to talk. All right, so when you have a bleed, so you have this ulcer that has, you know, got really deep and now it's opened up. So things are bleeding now. So when you have this bleed, you are going to go into shock along with that. So you're going to see signs and symptoms of shock. So when you see people who are in shock, what do you see? What
Feeling it?
happens to your blood pressure?
Goes down.
It goes down. What happens to your heart rate?
It goes up.
What happens to your breathing?
It gets more rapid.
Yes. And then this person could also have an episode where they faint, or they could be really dizzy. They could have nausea that goes along with this. All of those things have to do with shock, so you need to know that. Let's see. All right. One other thing I just wanted to say real quick. You remember when we talked about the different surgical management that you could do for, you know, peptic ulcers? So like obviously you start with the medicine first, and if the medicine doesn't work, you could move on to surgery. So we said there's a vagotomy, a pyloroplasty, a Billroth 1, and a Billroth 2. So the Billroth 1 and Billroth 2, what do they do in that particular surgery? So because this person has all of these issues with gastric acid secretion and everything, they're going to do something called an antrectomy, where they remove one part of the stomach called the antrum, and they make a surgical connection to the duodenum or to the jejunum. That's what they do in that. And because they remove that antrum part of the stomach, that's the part that causes more of that gastric acid secretion. So that's why that would help. So you need to kind of understand a little bit about that surgery. Okay, let me think, what else? Okay, I think that's mainly the stuff that is in that second part of the test. It's just all, you know, things that we just talked about. So there are going to be 2 math questions on this test. They are about time. So let's talk about that real quick so you know how to do it. Let me think here. All right, so if we had a math question that said, you're giving 3 liters of IV fluid to someone and you want it to go at 150 milliliters per hour, how much time would it take that to go in? So 3 liters is going to be, let's see if I can draw this, 3,000 milliliters, right? And then we said it was going at 150 milliliters per hour. So you take your 150 and put that on the bottom and then just divide. So what do we get for that?
20?
Yeah, so that would mean it would take 20 hours for that to go in. So super simple, right? So that's one of your questions. It's going to be similar to that. And then the other one, I got to see if I can figure this out real quick. If we had, I don't know if this is going to work out right. I have to change my numbers a little bit. We had 1 liter or 1,000 milliliters. And we want it to go in at 200 milliliters an hour. What do you get for that?
Five.
Yeah, so this would just go in over 5 hours. So the other part of this question is it's going to say, hey, we're going to start this at 6 a.m. So what time would this be done? So if you did this and you said, hey, it goes in 5 hours, then you would add 5 to 6, right? So if we started at 6 a.m., what's 5 hours from 6 a.m.?
11.
Yeah. So that's what time it would be done. So that would be kind of how the other question is worded, something similar to that. Make sense?
Sure.
Yes.
Okay. So very easy math questions. So I wanted to do that on purpose so that it wouldn't be too difficult. Now, there is something else to these time questions that I was going to show you if I could figure out an actual numbers that would work here. So if you did something like this where you had an amount that you divided by what it says in milliliters per hour, say you got 5.5. What are you supposed to do with that 0.5?
Round it up.
No.
Ah.
Good guess though. So yes, it would still go in 5 hours, but then you have to figure out what to do with this. And this is all you do. It's super easy. So you take 0.5 and multiply it by 60. What do you get if you do that?
$30.
30.
Yeah, it's 30. So that would mean that this would go in 5 hours, 30 minutes. So if I said 5.2 or something, you would take the 0.2 and multiply it by 60 to get the actual minutes. So you can figure this out to the actual minute on things without having to just round stuff. Does that make sense?
Yep.
Yes.
And then if you ever got, say you get something that said 6.33, then this 0.33, it's like a repeating number. You would just take those two numbers after the point, 0.33 and multiply it by 60. That's how you figure out those repeating numbers. Or if you had 0.75, 0.75, 0.75, it repeated like that, you just take the 0.75 times 60. Okay?
So I have a quick question. So you multiply by 60 only when you have a repeating number then?
No, always, whatever, if you get point whatever, for your thing. So if you have your amount that you're going to do, your 3,000 divided by 150, if you got 5.25 or 5.3 or 5.1, you're not going to be able to figure out your minutes just right with that point whatever. So you have to figure out your minutes, and the
Oh, I
only
see.
way you do that is to multiply it by 60.
So then when it's asking for minutes specifically.
Yes.
All right, thank you.
Any time question, you want to figure it out to the actual time. Okay? So that's all that is. So that's how our math is. Does anyone else have a question about that? So really, it's only just a matter of dividing, and you should be able to figure this out. All right, so that's that part. So now we get to go over all the other crazy stuff. Okay, so the other half of the test, we go over a little bit about different types of IV issues. Like, you know how in the one chapter we talked about IV fluids and IV sites and like complications and stuff? Tell me about what you remember about complications of an IV site.
Infection.
Okay, what else?
Phlebitis, infiltration.
Yes, tell me the difference between the two.
Infiltration, you usually get, I think, edema, and it blanches a little bit, maybe, and it leaks.
Okay,
And I think phlebitis is really bad, where it's like an infection. You see like a red line going up the vein.
yes, so phlebitis should always be really easy to pick out because of that red streaking up the vein. So you always would see that in the question if that's what they were trying to get at. Now, the infiltration is different. So a lot of people get confused and they think that you have pain there. You don't always have pain associated with infiltration. So your big signs and symptoms of that would be swelling right where it's in at, and then that temperature change. So if you put your hand right there where the IV goes in at, you would feel a difference in temperature from a different part of their skin to that. So usually it's going to feel cool to the touch. And again, you could have some leaking that goes along with that too. So anytime you would have that infiltration or phlebitis, you always would want to stop the IV and discontinue that, right? What would you do for an IV site that went bad? Like, what could you do for that patient to make that area feel better?
Topical stuff.
Okay, like what?
Mm,
Usually like a warm compress might be a nice thing, especially for an infiltrated site. Like they always say warm, moist heat to stick on there. So obviously you wouldn't want to leave it on all day, you know, like 20 minutes at a time or something would be a good thing. And then the other thing that we talked about with this stuff was the different types of IV lines. Like we talked about central lines a little bit. So remember we talked about PICC lines and med ports and implanted and not, what am I trying to say? Here, let me find it. Implanted, non-tunneled, and tunneled catheters. So there's 4 kinds there. So what kind of central line would you pick for someone if they had to go home with IV antibiotics? Out of those 4 central lines.
Implanted?
No,
Oh, okay.
that's okay. You would pick a PICC line. So there's a reason why you would choose that compared to the other ones. So let's talk about this for a minute. So a non-tunneled central line would usually be a line that's up in your neck up here. So this would be a temporary line. You would not leave this in for weeks and months at a time. This kind of line, this non-tunneled, would be one that's more at risk for infection. So that's why you don't want to leave this in for too long. This would be one that, like, say you worked on a med surg floor and someone, you know, started to go bad and you had to send them to ICU and they had to put in a central line, they'd probably put that type in just for a short period of time for them. Now, the tunneled central line would be more like, you know, someone has, someone who has to get dialysis or something, so they would get a tunneled central line in their upper chest area up in here. That would be more of a tunnel type of a thing. And that's usually because, you know, all of their sites that they would have normally for fistulas, they don't have good sites anymore. So maybe they had to put in a tunneled because of that. So typically you're not going to put in something like that just for IV antibiotics. And then the med port med ports could be in for a long period of time. So a med port is something that they have to surgically put in. And remember, it has like that little button area, I guess, that's underneath your skin. So you don't even see it outside of your body, but you could feel it. There's like a little bump there. So that is something that you can access and de-access every time they come into the hospital. So this would be more appropriate for someone who has chemotherapy or someone who has to get plasmapheresis all the time or something like that. So when they come in, why would you want to put a new IV in them every stinking time, right? So by having this, it makes it easier on the patient and easier on the nurses because you can just access and de-access when you need to. And that you can have in for years. I mean, that's like a long-term type of a line. The PICC line is something that you can have in for a long period of time, but not as long as the med port. So the PICC line would be something that you would choose for someone who would have to get long-term antibiotics because, yeah, you can have it in longer than a peripheral, and you could easily give, harsh antibiotics through this without, harming the patient. Because a lot of times when people have to get the IV antibiotics, it's usually something that's kind of, like a vancomycin or something like that that's kind of harsh on their veins. So that would be the most appropriate one to choose. Does that make sense?
Yes.
Okay.
Yeah, makes sense to me.
Okay. Again, if I were you guys, since you're not remembering this stuff about this stuff, go into your ATI and there's a module about central lines. Go in there and look at that. And that way you could just read through that stuff and you can familiarize yourself with it again. So there is something about that on here. Let me think what else. Oh, we talked about the different types of IV fluids. Remember isotonic, hypotonic, hypertonic. There's a video on that on your Canvas that I would encourage you to watch again to make sure you have this stuff down. So there is a couple of questions on that. So if we had someone who just came in for basic dehydration, what type of IV fluids would we give them? Isotonic, hypotonic, or hypertonic?
ISO.
Yes, it would be isotonic. Remember, isotonic fluids, you have the same on the inside of the cell as you do on the outside of the cell. And nothing changes. When you're giving that fluid, it stays the same like that. So if someone was dehydrated, you want to like put more fluid outside of their cells, to get them hydrated, but you don't want to have all of that move inside the cells either. You want it to stay in the right spot. So that would be why we would choose that. So give me an example of an isotonic IV fluid. Normal saline, right?
Yeah.
And D5W.
Okay. What else?
Lactated ringers.
Yeah. So those would be isotonic fluids. What does hypotonic fluids do, and why would you give those to someone? So remember, hypotonic fluids, you have more fluid and solutes inside the cell than you do outside of the cell. So your cell would be like fat, okay? So all of the solutes that were outside saw there were more inside, so they keep going inside. So all of your stuff outside of the cell is not going to be as much, but you're going to have more inside of the cell. So sometimes people have dehydrated cells, so that's why you would want to give this fluid to them. An example of this would be someone in DKA. they get very dehydrated. So you would give them a hypotonic fluid for a certain period of time to get their cells hydrated again. Obviously, you would not leave someone on this type of fluid continually, because what can happen is your cells can lysis or break up and explode. So you wouldn't want to leave them on this for too long. So you would constantly watch their labs to make sure that things are improving. And then once you saw that they improved enough, then you would take them off of that and put them on a different kind of IV fluid. What would you be at risk for if you had all of this stuff going into your cells?
Cell, like,
Overload.
I didn't hear
maybe
you.
like cell breakdown, like the cells can burst.
Yeah, we already said that. But what other kind of thing would be you'd be at risk for, like assessment wise?
Oh,
Hypovolemic shock.
Yeah, you're right, possibly, because we're pulling all of that fluid outside of the cell, inside of the cell. So all of that outside is going to be a lot less. So you're right, you could be at risk for that. Although that wasn't what I was getting at, but that's okay. What else?
Is it increased intracranial pressure?
Well, yeah. So if someone had too much pressure somewhere, like increased intracranial pressure or even intraocular pressure for some reason, you wouldn't want to give them this, because this would make it worse. So yeah, you definitely would not want to give this type of fluid. What type of fluid would you give that person?
Hypertonic?
Yes, because what does hypertonic fluid do?
Moves the fluid out of the cell.
Yes, so all of the fluid would be outside of the cell, excuse me, and then your cell would shrink up a little bit. So all of the stuff that was in the cell wouldn't be as much. So what would you be at risk for if you had hypertonic fluid going? Think about it for a minute. So you just pulled all of that fluid outside of the cell. So the fluid surrounding the cell would be a lot. What would you be at risk for?
Shrinking the cell.
Yes, but that's not what I'm talking about. You have too much fluid outside of the cell now. So if you were assessing someone, what do you think you'd
Oh.
see?
Edema.
Maybe edema. What would their lungs sound like?
Oh, they'd be filled with fluid.
Yes. So you'd be worried about pulmonary edema.
Yep.
So anyway, that's the kind of thinking you need to have when you're thinking about these IV fluids. What's going on with the cell inside and outside? And then what would you see going along with that? Okay. So definitely review that video and do some practice questions on her thing about it, because it'll help you. So you do have, like, I don't know if it's 2 questions. I can't remember how many I put on about that, but there's a couple questions on that. Other stuff in here, we talked about a little bit about fluid volume overload, fluid volume deficit. So when someone has fluid volume deficit, what's the best way to check their fluid status?
Monitor their urine output.
What
That's
else?
probably a stretch.
Vitals.
Okay, what else?
Daily weights, maybe.
Yeah, that's what I was looking for, a daily weight. So your weight is a really good indicator of your fluid volume. So you would be looking at that. Other stuff that we talked about would have been some of these electrolytes. So how much do you guys know these values? If I asked you, what's a normal sodium value, would you be able to tell me?
135 to 145.
Thank you. What's a normal potassium level?
Like 3.5 to 5.
Okay.
Sweet.
What's a normal calcium level?
8.5 to 10.5.
Yes. What's a normal magnesium level?
1.5 to 2.5.
Okay. What's a normal phosphorus level?
2.5 to 4.5.
There you go. And then what about chloride?
Mm, 95 to 105 or 110. 105.
Yeah, I just say 105.
All right.
Yeah, that's good. So if you know those values, it's going to help you be able to answer things correctly on the test. It's not like I'm going to ask you, hey, what's a normal value as a question, but you may have like, hey, this person has a calcium of 7.2 and they have these symptoms. What would you be looking for? If you didn't know that 7.2 was low or that it was normal or whatever, then you would have a hard time answering the question. You see what I mean? So definitely know those values. Okay, so certain things I want you to pay attention to when you're looking at these electrolytes. Foods, okay? So there's a couple questions on foods. So if we said someone had to be on a fluid restriction, think of like sodium levels. What kind of sodium level would you have to be on a fluid restriction?
Well, it'll be high
Yeah,
increase.
yeah, it's going to be high. So if we wanted you to stay away from sodium in foods, what kinds of foods are high in sodium?
Salt.
Yeah. What else?
Bacon.
Bacon.
Processed foods like canned foods.
Yeah, definitely.
Everything yummy.
Yeah, really. So yeah, stuff that has lots of salt would be things like hot dogs, lunch meat, cheese, butter, bacon, canned foods, all those types of things. So know that kind of stuff when it comes to these foods. Another thing that I want to point out, when we talk about potassium, so remember potassium, when you have low or high, it can be bad for your heart. So you're supposed to think more cardiac things with the heart going on with potassium. So with this, how would we get potassium to come down if it was too high? What would we give people?
Diuretics.
Okay, what else? What's the number? Yes, thank you. I was going to say, what's the number one thing we would give? What else could you give possibly to help potassium to come down?
What was that she said previously? I didn't hear.
She said Kexalate.
Okay.
Believe it or not, you can actually give insulin sometimes to people when they have a really high potassium, and that will kind of move the potassium where it needs to be, like back into the cell. So there's some like weird things like that you could do for high potassium. Other stuff. So if someone had a low potassium, so say we are, I don't know, 3.2, Would I want to give them an oral potassium supplement or a IV potassium?
It's not that low,
Oral?
so
Oral.
Yeah, so if it's not very low, you're going to go for oral every time because oral is going to treat it better and it'll stay up for longer. Now, IV, you would reach for if it was really out of whack. So like say I'm at 2,
1.
1 or 2, yeah. So if I'm super low, I'm going to give IV potassium. Do you ever IV push potassium?
No.
No. Why is that?
Because you have to just give it slow.
Well, what can happen if you give it IV push?
You mentioned it's cardiac related, so maybe heart attack, things like that.
Yeah, you could stop the heart.
Yeah.
So when you give IV potassium, it always comes as an IV piggyback. So it'll come in a little bag. And you cannot infuse it really fast with people. So do you know how fast you can infuse it? It's like 10 milliequivalents per hour. So that's kind of important to know. And then when we talked about calcium, there's a ton of stuff to kind of remember about calcium. So first of all, remember the correlation between calcium and phosphorus. So if your calcium is high, your phosphorus is low. If your phosphorus is high, your calcium is low. So they have an inverse relationship. So remember that because that will help you. Other things with calcium, remember it's always going to be something about your muscles and like your, what am I trying to say? Like your symptoms are going to be more muscular related, I guess you could say. So like your reflexes, remember like the trousseaus and the chopstick signs, all of that has to do with calcium, low calcium. If someone has like muscle twitching or tetany or spasms, that's a red flag that they have low calcium every time. So do you guys remember we mentioned a little bit about a thyroidectomy and a parathyroidectomy? And we talked about this on our discussion questions. You guys were doing that a little bit. So with those particular surgeries, you are at risk for low calcium. So anytime you see anything, related to that, it's always going to be low calcium every time. When someone has low calcium, we are going to be really worried about safety with them. So that's always an intervention, like safety precautions, because they'd be at risk for falls. They would be at risk for seizures. So you would do seizure precautions with them. So yeah, so think that way when you're thinking low calcium. Do you guys remember when we talked about some of the, I think I mentioned, I don't know, maybe I'm wrong, but I think I mentioned this. So when you have kidney disease, like say I have chronic kidney disease, I have a problem with too much calcium in my system because I have this kidney disease. I can't get rid of my calcium. So if I have too much calcium, what kinds of things would I be at risk for?
I can give you kidney stones.
It can give you kidney stones, you're right.
That's all I remember.
Cause cardiac issues.
It can cause cardiac issues, you're right. Anything else?
Does it have to do glucosteroids, corticoids?
Well, what I'm getting at, I was trying to get someone to say that sometimes you can have weakness of your bones and your muscles a little bit. So even though you're producing too much calcium, like you think about your bones and how your bones are forming and stuff, you would sometimes not have a really strong bone because you have too much stuff that's like trying to form together. So it doesn't form strong because there's too much of it. So again, this person would be at risk for some safety things as well. These people are going to be at risk for absent reflexes. They could be disoriented. They could have constipation. So pretty much with high or low calcium, then you're going to have to do safety precautions. You're going to be more at risk for seizures with low than you are with high. Okay, then with phosphorus. With phosphorus, one thing that I want you to remember is, again, like I was trying to say with the calcium, so when you have chronic kidney disease, you have too much calcium, so you don't have enough phosphorus in your system. So in order to fix that in that type of patient, you have to give them a certain medication to bind with their calcium to get it out of their system so they can use what little phosphorus they do have. Do you guys know what that's called? This is called Phoslo, Phoslo, Phoslo. There's other names for it too, but that's the one I want you to remember mainly. So with that pill, you take it 4 times a day pretty much, or you could take it even more than that, I guess, if you had to. But basically every time you eat, you're going to take this and it's going to bind with the calcium that you eat and like make it come out of your system so that you can use this phosphorus. So every time you eat, you would take it. Okay. What are some foods that are high in phosphorus, you guys?
Fish,
Okay. What else?
Potatoes.
Nuts.
Okay.
Like meat, like turkey, pork, stuff like that, right?
Yeah, it's more the meats than anything. So the list that I had on the PowerPoint, we had fish, organ meats, nuts, pork, beef, chicken, and whole grains. So if someone has, too much phosphorus in their system and not enough calcium, you would have to really like restrict how much meat they have, right? So their proteins and stuff would be a lot less. So just kind of keep that in mind. Let me think, what else? Oh, something I forgot to say when we were talking about potassium. There is a medication that sometimes people will be on called digoxin, that if you take digoxin and you have a low potassium, it can cause dig toxicity. So this means like, there's a ton of people who are on digoxin. There's a lot of people who take it for heart failure and they take it daily. So you would need to, if you were their nurse, you would need to monitor their labs all the time to make sure that their potassium wasn't too low. So if you did see that it was low, you would want to treat your potassium before you give that digoxin. Make sure your potassium's up because you don't want to cause toxicity. All right, and then with magnesium. Magnesium is going to cause you to have decreased reflexes. So when we're talking about that, we're talking about, hold on, let me find it. We're talking about high magnesium. So like when we're talking about deep tendon reflexes and stuff, that would be something that you would pick out and be like, oh yeah, that's high magnesium. So when you think of your symptoms with magnesium, like if it's high or low, if with high, all of your symptoms are going to be like lethargic, like everything's going to be slower. So like your EKG changes are going to be like widened QRS and everything. So everything's going to be like slower on the EKG. Your tendon reflexes are going to be absent or diminished. You're going to have low blood pressure. You're going to have slower respirations. Like everything's going to be slower. Whereas with hypomagnesemia, everything's going to be the opposite. So it's kind of like opposite with those.
So with hypomagnesemia, would you be like extra twitchy?
Yeah, you could be. Mm-hmm.
Okay. Because like I get all twitchy. My mom's like, oh, you must have low magnesium. I'm like, oh, okay.
Yeah, it's actually the opposite. So yeah, just kind of think of that when you're looking at any kind of magnesium question. You have to make sure that you don't get that mixed up. All right, how do you guys feel about the acid-base stuff?
Like the alkalosis acidosis stuff?
Yeah, if you have to just look at something and pick out, hey, is this respiratory acidosis or alkalosis or whatever, would you be able to pick it out?
No.
All right, so you want me to go over that real quick?
Yes, please.
Yes, please.
Yes, please.
All right, so with these, we'll probably have maybe 4 to 5 questions on this, something like that. So again, values that you need to remember would be your pH. So your pH needs to be 7.35 to 7.45. Your PaCO2 needs to be 35 to 45. And your HCO3 needs to be 22 to 26. Those are your basic ones you need to remember. So let's talk about like how you would read an ABG. So if you had an ABG that said, this person has a pH of 7.44. They have an PaCO2 of 30 and an HCO3 of 21. So let's see if I can. Okay, I don't know if I can write this or not. All right, so, oh, that's not right either. Darn it. There we go. Maybe this is it. Okay, so we said 7.44. It's hard to write with I don't have a mouse, so I'm like trying to do this without a mouse. All right, so that's our pH. So is that acidic or alkalotic? Or is it normal?
Normal.
It's normal, right? Because we said 7.35 to 7.45. So remember on that video I showed you guys forever ago, the tic-tac-toe thing? So you draw your tic-tac-toe. And this is acid. This would be normal. I'm just trying to, and this is base. I can draw it. Okay, so we would put our pH here. Okay, then we said 30 was our PaCO2. So what is that? Is it acidic or is it alkalotic? And remember, respiratory is opposite.
Alkalotic.
Okay, so that would go under our base column. So we would put, well, I'd put it up here, I guess. PaCO2. Okay, and then our last number was 21. This was our HCO3. What is that one?
Acidic.
Acidic. So that would go here. So we're going to put our HCO3 here. Okay, so when you're trying to figure out what this is, you know how we learned about what's compensated and what's not? You can figure out what that is right off the bat by looking at this. Okay, so this is fully compensated because our pH is under the normal column. So this means that all of our body's things that it tries to do to get our pH back to normal were successful because it did get our pH back to normal, even though these things aren't quite back to normal. So that is compensated. So that would be part of this. All right, and then what else would you say about this to figure out what it is? All right, so remember we said 7.35 to 7.45 was our normal pH, and we have 7.44 here. Is that closer to acidosis or alkalosis?
Alkalosis.
Right, so we know we have an alkalosis going on then. Okay, so what is in the column that the PaCO2 is in? This is your basic column, right? So this is the alkalosis. So we know it's respiratory alkalosis. So we already figured out that this was an alkalosis problem we had. So we look in that alkalosis column and we see what's in there. And it's the respiratory part. So it's respiratory alkalosis. So this would be compensated respiratory alkalosis. That's what this is. All right, let's try something else. Okay, what if we had a pH of 6.98?
Well, they'd probably be dead.
And we have a PaCO2 of 30. And we have an HCO3 of 18. Okay, so we do our tic-tac-toe. So acid, normal, base. Okay, so 6.98. That is really low, right? Because we said 7.35 to 7.45. So this would be in the acidic column. So we would put our pH here. Okay, 30. Is that acidic or alkalotic?
Alkalotic.
Okay, so we would put that over under the base column, so PaCO2. Geez, I cannot draw with this. All right, and then the 18, where would that go?
Acidic.
Okay, so that's going to go over here, HCO3. Okay, so we have a tic-tac-toe here, right? So we know that we have, you're going to look here and see what you have. You have metabolic problem because it's HCO3. So it's metabolic acidosis. And then you're going to look over here to see what this is doing to figure out if you have compensation or not. So how would you judge if you have compensation or not here?
Would it have to be in a normal range to have compensation?
Yes, but there is uncompensated, partially, and fully compensated. The last one we did was fully compensated, right?
Then this one is uncompensated.
So uncompensated means the pH is outside the expected reference range, which that's right. And either the HCO3 or the PaCO2 is outside the expected reference range. So it's only one of these two that would be not normal. So I think it's partially compensated. Partially compensated means you have the pH, the HCO3, and the PaCO2 all outside of the expected reference range. So this would be metabolic acidosis, partially compensated. Don't worry too much about the whole compensation bit because I'm almost positive I don't have a whole lot about that on there. I think like when you have to figure these out, you just have to basically say if it's respiratory or metabolic acidosis or alkalosis. I'm almost positive that's how I have it. So
Mrs.
again,
Schilt,
yes.
are we able to with the questions for these to figure out if what they are we able to like draw the tic-tac-toe and figure it out that way and write it down
Yes,
to do
because remember you're allowed to have a scrap piece of paper and something to write with and a calculator at your test.
Okay.
So definitely, I would encourage you to do that. So like when you guys are doing your test, I would encourage you to write stuff down on your scrap paper so you remember this. Let me erase all of this real quick. So I would encourage you to write down your normal values up top here, and then that way you remember them and you can see, you know, what's alkalosis, what's acidosis, and then do your tic-tac-toe so you can figure out what it is. If you feel uncomfortable with this, you need to be watching those videos. I'm telling you, they help. I have probably 3 or 4 of them on your Canvas under your module for this stuff. So go to it and look at it. I'm telling you, it helps you. Also, in your ATI book, it's chapter 45. It's all about acid-base stuff. In the very back portion of that chapter, That's where it talks about all that compensation stuff. If you have a hard time remembering, it's all right there. It spells it out for you what's what. So that's something that you just kind of have to memorize about the compensation to see what everything is. The other stuff that you would have to know concerning this stuff. So when we talked about this, we talked about what is respiratory acidosis and what causes it. So respiratory acidosis is usually going to be caused because someone is not ventilating well. So remember, this could be all kinds of different pulmonary conditions. So, hey, maybe I have pneumonia, or I have a PE, or maybe I have an airway obstruction. Maybe I swallowed something I shouldn't have and now I can't breathe. You know, it could be anything like that that could have caused it. The other thing I want you to remember is that certain conditions like muscular conditions, like say muscular dystrophy or Guillain-Barré syndrome, those types of things, you don't think of those as being respiratory, but they do have a respiratory component to them because like with that Guillain-Barré syndrome, you have progressive paralyzation, like moving up your body. So as it moves up, you're going to have your diaphragm paralyzed, so you can't breathe anymore at one point. So that would be this. Same with like, you know, muscular dystrophy. I was telling you guys about my sister-in-law. She has a hard time breathing now because as her muscular dystrophy is getting worse, she doesn't have that strength, you know, with her diaphragm to be able to breathe well. So hypoventilation is what you need to think about when you're thinking about respiratory acidosis. We always want to treat the underlying cause with every one of these. So if it is pneumonia, how do you treat pneumonia? You give antibiotics, you give oxygen, you know, all of those things. That's how you would treat it to get it better. So that's kind of how you need to be thinking about these. So respiratory acidosis, I think, is pretty easy to remember. Respiratory alkalosis, again, I think is pretty easy as well. Alkalosis, you need to consider that hyperventilation. So this is someone who is very anxious. So if you think about the anxious person, what does someone look like when they're super anxious? What do they do?
They're breathing rapidly.
Okay.
Shaking or twitching.
Yeah. So that one I think is pretty easy to pick out. So you can have really fast breathing, you can have tachycardia, diaphoresis, you know, the whole 9 yards with that. So with those, I think that's pretty easy to pick out too, just because usually in the question it'll say something about, oh, you seem anxious or something. And then you'll be like, oh yeah, that's respiratory alkalosis. So again, how do you treat someone who is really anxious?
Paper bag.
Yeah, have them breathe into a paper bag, and usually that will help it, believe it or not. So it's either something like that, or maybe you're giving them something for anxiety, or, you know, maybe there was another cause, and whatever the other cause was, that's what you're trying to fix. So just kind of be familiar with some of these different causes that go with these different things. Okay, and then metabolic acidosis. So with that one, this is the one that is synonymous with DKA. So if someone has diabetic ketoacidosis, usually they'll go into this. So with this one, you have a lot of weird kinds of symptoms. So you would get deep, rapid respirations. And sometimes a question, if you get a question about it, it'll say something about Kussmaul respirations. Those are like, you look like you're short of breath, but it's not, that's not really what the problem is. Like, you could put oxygen on them, but it's not going to fix the issue. The only thing that's going to fix that is by treating their blood sugar, because their blood sugar is out of control. Other stuff that they could have going on, they may be really confused. They could have GI problems, like maybe they're vomiting or sick to their stomach. They could have a low blood pressure. They could have a high potassium that goes along with this. So it's kind of odd symptoms, but that's metabolic acidosis. So with this, again, treat whatever the underlying issue is. So if it is because they're in DKA, you're going to be giving them some IV insulin, and that's going to take care of this. With metabolic alkalosis, this is something where you're going to have a high pH and a high HCO3. So some of the causes of this would be because you maybe have prolonged NG suctioning, or maybe you have diuretic therapy that you're on. Maybe you have excessive vomiting or nausea or something. Excessive intake of bicarbonates as well, like taking lots of antacids. That would be another reason for this. So again, treat the underlying cause, and then that's going to fix this. So there's going to be a couple of questions that will just like read off a scenario to you and say, oh, this person has this, this, and this going on. Which acid-base problem is it? And then you would have to pick it out. So again, registered nurse RN has a bunch of practice questions on these. If you wanted to do that, that would be helpful to you. And again, look at some of my stuff that I already have posted on Canvas. I think that would be helpful. Brandy, tell everyone about your website that you found about ABGs.
Oh, I didn't write it down.
Was it something like ABG Ninja or something?
Yes, it's yeah, I just stumbled upon it trying to find some practice questions on how to do the ABGs, and I found it. It gives you a lot of questions, and with the compensated and fully compensated, all of that with explanation and reason, and you can just keep trying them over and over again, like different questions. So it was really good. I practiced quite a few of them to tell you which parts of the question do you have wrong or right, and
Yeah.
what your reason is.
I looked at it a little bit. I thought it looked pretty good too. So obviously you guys can try that if you want to as well. So as you're studying for this, this is what I'm going to tell you. You need to make sure that you've done some reading. And I know maybe you did reading a long time ago and you just don't remember certain things. So what I would do, I just went over like most of what the test is going to be for you guys, so you know kind of what to expect. So if you don't feel like you know certain things, go back and look at it. So go back to your ATI and look at those modules I told you about to get familiar with those things. Go, to all of your extra resources that I tell you about and use them. You have all these different resources. You could use Picmonic. You could go to that registered nurse RN, do that ABG Ninja she was just telling you about. There's so many things. So use your extra resources. But you also need to have a basic knowledge about stuff. So if you don't know something, make sure you read about it so you get the best chance of knowing how to answer something. Any other questions?
Nope.
Okay. All right, well, I'm going to let you guys go. I do have some remediation I'm doing with people today. If you did not sign up for remediation, you need to get it done today. So I think I have most of you. There might be like 1 or 2 people left that need to go. So just please email me and I'll give you a time. So if you guys have any other questions, get a hold of me, okay?
I had a question about the hypotonic fluids.
Okay.
I just wasn't able to write something down that you had said. I missed it. It was just the risk for hypotonic. So I know the pulmonary edema is for hypertonic, but I didn't get the hypotonic risk.
We basically already talked about it. So you remember how you said, oh, well, they're going to be at risk for cerebral edema and stuff. Yeah, they would be because they have all this fluid that's inside their cells now. So anything where they're going to have like increased intracranial pressure or increased interocular pressure, any kind of increased pressure like that, that's not a good thing to have going.
Okay, thank you.
Any other questions?
Bye, Miss Silk. Thank you.
Sure. We'll see you later.
Bye.
All right, guys. Again, if you have any other issues or questions, just get a hold of me, okay? I'll see you on Thursday.